cases, who tend to be family members, for example, because a lot of the transmission was in households. So they would be loved ones that live in the house. They could be older, they could be younger. Now what we're seeing is the asymptomatic or asymptomatic individuals are being found in outbreaks, in these outbreaks in expat dormitories, for example. And so in this situation, you're doing a lot of testing. You're actually looking, there's many countries that are looking for the virus. And this is part of the strategy to bring the virus under control. And in many of those, asymptomatic people and again, there's still a lot of unknowns here, so I don't want to overgeneralize, but asymptomatic people who are positive tend to be younger, tend to be people without underlying conditions. But again, I don't want to overgeneralize what we know right now because there's still so much unknown and we're not systematically testing. Our strategy for suppressing virus and saving lives relates to testing suspect cases and testing contacts who develop symptoms. And so in that strategy, you may miss asymptomatic cases, but in outbreaks and in certain types of situations, they're doing more broader testing. And that's where we're learning a bit more about those asymptomatic cases.
Yeah, and maybe I could just add to that, because I think this is an important point. Countries that want to do more extensive testing, that is really to do with the resources in the country and what the government can achieve with broader testing and more popular. But at the core, you need to be testing the suspect cases.
Yeah.
So there's no point just doing, you need to target your testing and target that testing against those individuals who are likely to have the disease so you can identify their contacts and break the chains of transmission. If in addition to that process, you can do further testing, you can, for example, do preemptive testing in long-term care facilities or test health workers or other things, then yes, that's a good way of managing risk. But just doing blind population-based testing without doing those other things, I think at this stage you'd have to really question whether that's the best use of resources. I think you have to use and particularly in developing countries who don't have access to massive amounts of testing, they really have to use the resources carefully, and they have to use them wisely, and they have to use them tactically. And I do think in that sense we need to focus in on diagnosing suspect cases, identifying their contacts, quarantining contacts, supporting those contacts in quarantine, and using that as a primary strategy. And testing is part of that. If you have a further capacity to test and you can do more, absolutely, please do. But you do need to use your testing as part of your surveillance and control strategy as well, in a targeted way.
And WHO has guidance on that as well, suggesting what kind of strategies countries can consider. It's not what they have to do, but we have that out there so people can consider it.
Yeah, what we've done is we've tried to support countries based on the type of transmission scenario they're in. You know, what are they facing? Do they have a few cases? Do they have clusters of cases? Do they have, you know, widespread community transmission? And that will make countries have to prioritize the use of what they have. And so what we've done is we've tried to provide guidance to support them in the best use of the resources that they have.
Take a few more questions here. We have one from Jen Steinhardt. She's asking, are there studies that suggest when patients are the most contagious? I imagine it's still difficult to say, but curious to know what we know so far.
So that's another really excellent question. Yeah, we should do more of these. No, that's a really excellent question, and that's another one of the big unknowns is not only who is transmitting to others, it's when are they transmitting to others. And so data here is very preliminary. And again, we're working with a number of countries and labs, and we ask all of our member states to help us answer these questions to better understand when people are most infectious. What we have are a few studies, again, it's limited information, on when people test positive through PCR testing, and when they may have more viral load is what we say. It's more particles that
a lot of
virus in their body. Thank you. And it appears from very limited information that we have so far that people have more virus in their body at or around the time that they develop symptoms. So very early on, which is different than the profile we saw with SARS. And so that means we don't know actually when people are most infectious, but from that information, people with more virus in their body, may be able to spread more early on in infection. And then that tails off. What we don't know well yet is sort of the upper bound of like how long are people infectious. There's some preliminary studies from Germany, from the United States, that suggest that it could be up to 8-9 days for mild patients, but it could be a lot longer for people who are more severely ill. And that's why it's really important that cases are isolated and cared for appropriately so that we prevent that potential for onward transmission. But again, it's still early days, and it's still, we're trying to gather this information to help us really understand when people are most infectious.
And it's very important across all of infectious disease control. If we look at Ebola, I'm dealing with another Ebola outbreak in Congo right now, people tend not to be infectious at all until they get their fever, and sometimes for a number of days afterwards. So if you can detect everyone that has the fever, then you're sure that you're able to protect others and break the chains of transmission. It was the same in SARS, because people didn't tend to be infectious as early in the course of disease because the virus was in their lower respiratory airway. It was harder to infect others. So it's both, you need to look at the timing at which someone becomes infectious, and also where they're being infectious from, how easy it is for them to pass the disease from one person to another. So in this case, now as we look at COVID-19, we have an infectious pathogen that's present in the upper airway, for which the viral loads are peaking at the time that you're just beginning to get sick. Well, that means you could be in the restaurant feeling perfectly well and start to get a fever. Somewhat, you're feeling okay. You didn't think you need to stay home. But that's the moment at which your viral load could be actually quite high. And I think they're the kind of reasons why mask guidance and others is to say, well, in situations where you can't physically distance, there is this period of time when, even a professor of infectious diseases themselves wouldn't know that I'm getting COVID. There is that hours or days in which you're not that unwell, or you could be becoming unwell, you're not aware of your status. And it's because the disease can spread at that moment that the disease is so contagious. That's why it's spread around the world in such an uncontained way, is because it's hard to stop this virus.
But it's still possible.
It's still possible. If this virus was easy to stop, everyone would be doing it, right? It's not easy to stop. It isn't easy to stop. But what some countries have shown, many countries have shown, is if you go at this in a very systematic way, and you use a comprehensive approach, that there is enough stoppability in the virus. It's not so transmissible that you cannot suppress. We've seen that with the physical measures, social distancing. We've seen it with surveillance. You put all of these things together, and you just double down on your bets and say, we're going to do everything. Countries have clearly shown that you can have an impact on the virus transmission, and you can bring transmission down to an acceptable level, or even to no level, as our colleagues in New Zealand have recently demonstrated. So I think that's an important part of this. It's one thing, we have to admit, and everyone needs, and we've seen it, this is not an easy virus to stop. But we have to do our best. Just because something is not easy to stop, you can't throw up your hands and say, well, it can't be stopped. There's a difference between not easy to stop and can't be stopped. And I think while there are still many unknowns, we know enough, I think, that we need to, and if we're coming into a period, people have seen now in Europe and North America that the disease is to a great extent on the decrease of many countries. But that is not the case in Central Asia. That is not the case in Africa. That is not the case again in the Middle East. That is not the case in Latin America. I think the last couple of days have been the highest number of daily cases in the world. So in terms of pandemic generation, we are still very much on the upward climb on this mountain. And therefore we have to implement the measures that we believe will be associated with controlling the disease.
Because we've seen it.
Because we've seen it work in other situations, yeah. And we wish those countries, that's what we're here to provide, the best possible technical advice. No one has all the answers. No one has all the knowledge. The real trick is pulling all of that knowledge, pulling those answers together and working together to give the best possible scientific advice that drives policy at national level. In the end of the day, WHO doesn't tell countries what to do. Countries decide what they do in terms of policy. And they gather their own scientific information, and you've seen that. Many countries have their own scientific committees, they have their own modelling groups, they have their own clinical groups. Our job in WHO is to synthesize that at a global level, because some countries don't have access to that knowledge, but also it's always good to have a second opinion. It's always good to have your own national process and then look at what the rest of the world is doing. And the more we do that and the more we learn from each other, the more likely it is we will gain new knowledge. And then in 1 month's time, 2 months' time, and 5 months' time, we will know more, and we'll be sitting at this desk answering other unknown questions about this virus. And I think that will continue. Look at Ebola. We're still asking questions about Ebola virus. I've been responding to Ebola virus outbreaks for 25 years, and I still have more questions than answers. That is, unfortunately, the science and infectious diseases. We do not understand the microbial world, and particularly the emerging microbial world, as well as we should.
I think, Nika, I was just going to add, I think